Across the Middle East and North Africa, rates of gestational hyperglycemia have reached a staggering 22.3%. It is a mounting regional health crisis. Lebanon represents a specific clinical contradiction. The country is burdened by some of the highest adult diabetes rates in the region, making the health of its pregnant population a critical concern. This high disease rate stands in direct contrast to the country's reliance on the traditional Mediterranean diet, a lifestyle long celebrated as a global gold standard for metabolic health. This tension forces a difficult question for medical science. Is one of the world's healthiest dietary patterns failing to protect pregnant mothers? To find the answer, a national prospective study followed 618 pregnant Lebanese women, tracking their health markers and habits across all 3 trimesters. Researchers were monitoring 2 distinct metabolic risks: gestational diabetes mellitus, a formal mid-pregnancy diagnosis, and early-stage impaired glucose tolerance. The initial hypothesis was that the Mediterranean diet would provide a strong metabolic defense. The data was expected to show that high adherence to the diet would block these conditions from developing. But the findings shattered that assumption. Overall adherence to the diet provided almost no predicted protection against blood sugar impairment. Preventing gestational diabetes requires looking past broad dietary labels, focusing instead on specific biological and behavioral shifts that occur as a pregnancy progresses. In the first trimester, general adherence to a healthy diet score offered essentially no benefit in predicting early glucose issues. This chart shows the primary driver discovered in the first trimester. Mothers reporting high perceived stress saw a 3-fold increase in their risk for early glucose impairment. When dietary factors did appear, the culprits were specific cultural staples that are typically viewed as healthy, but served as dense carbohydrate sources that worsened early glycemia. Heavy consumption of burghul, a staple of the Lebanese diet, emerged as a major risk factor during these first few months. Excessive early intake of traditional legumes and beans further compounded the issue, driving up blood sugar levels when the body is most vulnerable. Early metabolic vulnerability is driven by psychological stress and specific carbohydrate loads, not by the absence of a generalized healthy diet. By weeks 24 to 28 of the second trimester, 5.6% of the cohort received a formal diagnosis of gestational diabetes. The data revealed that a family history of diabetes was the most potent predictor, increasing a mother's odds of developing the condition by nearly 400%. The researchers also identified a physiological predictor unrelated to nutrition: mean arterial pressure, or the average blood pressure within a mother's arteries. This plot illustrates the findings. There is a direct correlation between elevated arterial pressure mid-pregnancy and a confirmed gestational diabetes diagnosis. By mid-pregnancy, the onset of the condition is governed far more by genetics and vascular tension than by the contents of a patient's dinner plate. In the third trimester, the prevalence of late-stage glucose impairment climbs to 24%. A major factor behind this spike is excessive weight gain. 68.3% of the cohort gained weight far beyond recommended medical limits. This trend is linked to a near-universal drop in physical activity. By the third trimester, 94.8% of the mothers were classified as extremely sedentary. Amidst this behavioral shift, however, the data revealed one specific intervention that remained highly protective. High-fiber vegetable consumption drastically lowered the risk of late-stage glucose impairment, succeeding where the broader Mediterranean diet average failed. While late pregnancy risk is heavily influenced by a lack of movement, it can be significantly mitigated by targeted, high-fiber vegetable intake. These findings suggest that broad nutritional advice is no longer sufficient for managing gestational health. In the first trimester, clinicians should prioritize monitoring maternal stress levels and advising strict portion control for dense carbohydrates like burghul and legumes. For the second trimester, the protocol shifts to intensive screening of family history and the vigilant monitoring of mean arterial pressure. Finally, in the third trimester, the focus must move to public health campaigns that address sedentary lifestyles and promote high-fiber vegetable intake to manage gestational weight. Treating the timeline of pregnancy with this level of precision allows medical professionals to intercept glucose impairment before it becomes a formal diagnosis. This data provides a foundational framework for maternal care, offering insights that extend well beyond the borders of Lebanon. Modern maternal care requires treating pregnancy not as a single state, but as a rapidly changing biological timeline. By adapting our clinical strategies to the biological clock, we can better protect the health of mothers and their children around the world.